Yes, my topic is lower limb stroke rehabilitation with recoveriX. So let me show you what I prepared for you today. Yeah, today, firstly, I'll talk about the background, and then, and recoveriX for the lower limb, the rehabilitation procedures, how we treat the patient in terms of the software and all the detail, where the electrode and like that. And also I will show you the lower limb assessment. How do we evaluate patient improvement? And then some group results and some the case results. So why we are doing the treatment, especially for the gait rehabilitation, low limb rehabilitation. So efficacy of the brain-computer interface in stroke motor rehabilitation has been shown in the many literatures, in even multiple meta-analysis show that BCI is useful for the stroke patient to have more the motor recovery. Yeah, so that is why, so we are using the BCI technology for the stroke rehab. And previously, actually, using the recoveriX, the recoveriX system, we have shown that the recoveriX is very helpful for the patient with someone who had paralysis in the hand, the upper limb side. So we had the publication, and also we have showed that this is very useful for the patient. And that is why now it's time to move to the lower limb. But you probably have not seen many researches about using BCI technology to the lower limb. So that is why we actually want to figure it out. This is really useful for the working. Yeah. And another reason is that the lower limb, the working, is very essential in daily life. If we cannot move from the A to B independently, then it is a lot of the limited the daily life activity. That is why we try to use our system for the lower limb. Okay, here's usually what it happened to the patient after stroke. So most patients have got the hemiplegic patient, hemiparalysis. So there's one side, only the one side of the body has some typical, especially for the ankle, has the very most common. The symptom is the foot drop or drop foot. So the foot is toward the gravity direction. So they have to drag the foot, and then it may also not that safe. I mean, a little bit dangerous to break their foot. Yeah, that's why they have to swing externally like that way. So then actually really slow down the working, the speed, and a big obstacle for the patient to walk around and the free daily life. So during the working, we don't actually do it intentionally, but the dorsiflexion, this upward during the swing phase, and also pushing down to the ground to the plantar, which is plantar flexion, is happening, and also slightly the inversion, eversion, this direction is also happening during our locomotion or the walking. But it may be not clear how important it is by now, but here is I prepared some graphic for you. You can see it. This is actually we are working without any injury. Yeah. So basically, while we are working, the foot is actually a little bit flexed, and then this is freely, no any movement. So now I removed all the muscle around the lower limb, and only this one is the tibialis anterior muscle is shown here. Yeah. During this working, one of the examples we are using this muscle, and then this is how we work. Yeah. But someone had a foot drop after stroke, and let's see what will happen. Only I'm just simulated someone who cannot move or control of their ankle. Then what will happen was, as I said, the ankle is actually toward the gravity downside. So if they work like that without changing any degree in the hip and the knee, and actually they have to touch the ground, and then they may break their ankle. Yeah, you can see it here. Yeah. So that is why if you see the stroke patient who has the issue in the lower limb, naturally they actually have to the leg, the affected side of the leg is actually swing the outer way. Yeah. So they have to make a big circling. Yeah. Just to protect the ankle. Yeah. So it's a big degree here. Then what we actually want to achieve is probably patient may not completely control the ankle after any kind of a therapy, especially with our recovery therapy, but at least some able to move the ankle. And then if they be able to move the ankle a little bit more, then their working will be like this. Previously, the angle was like almost like this much, but since they can contract they move the ankle, so they don't have to make the bigger circle than like before. So it's more, so by doing this, the patient can work faster than before, and more or less chance to have additional injury to the ankle. So then they work faster, and then this probably related to the working tests the George shown before, this morning the Christoph showed before. Okay, so now let's talk about the recoveriX for the lower limb rehabilitation. So someone who, this is the way we do, this is very the simplified one. So may skip the many steps, but the way we work is from the brain, we send the command signal via the spinal cord, and or the spinal cord also they have the or different circuit, yeah, kind of the central pattern generator like that. So we can work, and all those from our body send also sensory feedback to the brain. So this is the way work, or the sensory motor closed loop. So this is happening. But someone who got the stroke, especially in the motor area, yeah, they cannot send proper signal to our body. And then because no signal arrived into our body, then the signal cannot come back to our central nervous system. So it's a basic, very vicious cycle, and it cannot work. So here is what the recoveriX can do. Yeah, recoveriX, the system can actually detect patient, the intention. This patient wants to move this foot or not. Yeah, then whenever it detected okay, this patient wants to move, then using the external device. Yeah, then move the foot, and the feedback, those sensory feedback from the muscle and tendon, and goes back to the central nervous system. Yeah, in this case, in the end, the cortical area. And then we do the repeat again. Then here we are expecting the neuroplasticity in the cortical area. And also in the meantime, also muscle will be ready to work better. So all those the bilateral benefit. So one of I would like to emphasize it again is in the rehabilitation. There is many important factors, elements out there, but one important thing is the intensity, how intensively patients get trained or to practice. That will be the important. And also, obviously, this related to that one is the repetition. People have to do patient have to repeat again, multiple times over weeks, at least some weeks. And we are expecting some patient improvement. And also how soon patients start the therapy, that will be also important. So here's when you probably have seen the figure so many times, but this is the concept of the brain-computer interface. So we are using this idea. Yeah, when patients try to move, and then the BCI system can detect and control this feedback device, and then controlling the patient's body, and then the feedback actually sent back to the brain, to the patient again, make a closed loop. So in our case, there is maybe the two type of the rehabilitation using the BCI. One is only apply the external devices connected to only the affected hand, affected side, for example, for the hand therapy. Yeah. So then they try to classify the active or inactive. But in our case, we actually try to do the left versus right. Let's keep that in mind. And here is actually the recovery system is working for the leg therapy, and system provide the command. Hey, try to move the left or right. In this case, then the EEG signal is analyzed by the system, and then whenever patient think correctly or as expected, then the system send the trigger saying, okay, then the avatar, we say avatar, the visual feedback will be provided to the patient. And the functional electrical stimulation, the FAST system will stimulate patient muscle. Then and then cause the proprioception. Then those two type of visual and perceptive feedback will be back to the patient. So then we do the many the repetition, and then patient will have the motor recovery and better movement. That is the idea of our recovery system. So then I said, okay, you said the recoveriX will help the patient. How? Where does the motor recovery come from? So as I said, yeah, we did during the repetition, and the brain is very plastic. So the brain is reorganize as we train, just like someone we learn the new sports or when we have the movement. Yeah, so those will happen because of the brain plasticity. Yeah, and also the fast therapy. So since we are providing the fast electrical stimulation to the muscle, so we are using the fast therapy, and especially fast therapy, neurofeedback therapy, and also the motor imagery, the mental practice therapy has been known, accepted by the therapists and clinician that those are good, effective for the stroke rehabilitation. So we are using FAST, and also this neurofeedback therapy is one part of the BCI, is one part of the neurofeedback therapy. And also during this therapy, patient have to imagine, yeah, practice a lot. So that is why another way we can actually tell why recoveriX has the good for the patient is combination of the three therapy. And also here is another way using because of also the brain plasticity. So it can be explained in the many different way why patient improve. So now it's coming to the how we prepare the patient. Yeah, as I said, yeah, we are using the EEG system. So we using the wireless EEG system, and also as I said, patients hear the command sound left or right. So usually we need the the healthy hand side as a kind of reference signal to classify the left and right. So we put even though this is a foot therapy, we put the fast electrode on the healthy side of the hand, which is the extensor digital communis. Yeah, so we can put the fast electrode on the hand, and then we will make the movement here. For the foot, the target muscle is the tibialis anterior muscle, and then we put the one pair of the electrode here. Probably this is better as you have already seen the simulation, the movie before. It is the same muscle. So we usually ask, before we put the fast electrode, we ask patient move their foot, yeah. But it's some residual movement is there, so yeah, we can feed it, yeah. Let's say this is the foot, yeah, the ankle, and then this is the lower limb, and then we can see which muscle is moving in charge of that movement. Then we can put the electrode there. But sometimes, yeah, you cannot, someone who severe stroke, yeah, severe impairment, you cannot feel it. In that case, you actually have to move your patient foot, and then if you put your hands there, then you can feel it, which muscle is moving. And then you can put the electrode over there. And since we want to make the stimulate the muscle, you better not to place the electrode over the tendon. Yeah, tendon is more like the connective tissue from the muscle to the bone. Okay, what you can do, what is really the useful tip, or what you have to do, keep that in mind, is you have to try the small stimulation energy for the nice movement. So to do it, best electrode location is really important. If you can do it, then with a small energy, you can have a really nice movement. Not like totally wrong direction, but very nice foot movement. If you can achieve with the dosage of injected current of the fast, then you can have obviously very nice movement. And since you are using the smaller energy, you have the chance of the discomfort is going down. Yeah. And then also, since we are using the smaller energy, the chance of the muscle fatigue will be low than when you use the higher energy. So always the placing the fast electrode is really important. So another the thing we have to keep that in mind is, yeah, location is important, but also stimulation, the amplitude is also important. Let's say, for example, you find a nice fast location, then you increase the amount of the or intensity of the stimulation. Yeah, in the beginning, you probably reached those sensory threshold. Yeah, then patients start to feel it. Okay, something is coming in. And then when you reach this motor threshold, then patient foot probably start to move a little bit. Yeah. Then if you reached about this way, and then you may have the patient's foot is moving nicely. But if you apply the tool more than that, then patient may start to feel the pain or discomfort. So always good communication with the patient, and how do you feel, or not too much, and those will be the important during the therapy. And here is the timing of the one movement. Patient hear the beep sound, ding, yeah. Then about the 2 seconds later, patient hear whether they have to imagine left or right. Previous case, the example, left hand versus right foot. Yeah, so then whenever they hear the right, then they have to imagine right foot movement. Then they have to continue to imagine until they hear the relax sound. So during the 6 seconds, the patient have to fully concentrate and imagine. This is the one trial or one movement. Then I will also explain this idea a little bit later slide. And then this is what we use for the BCI, the recoveriX, the training. So basically only the red electrode we are using, those all total 16 electrode. We are using the right earlobe as a reference, and here is the ground electrode. And as you can see it here, yeah, we are only covering here's the motor and then sensory motor strip of the brain, and then 16 electrodes are enough according to the research and from the other literature. So we are using only focusing. Since we are using the motor rehabilitation, we are only using the 16 electrodes, and which is good enough for the rehabilitation purpose. Here is give you the good idea about how we do it here for the recoveriX, the training with the actual patient. So in the beginning, patient hear the right sound. Then the right sound is actually the CZ is in charge of the right foot movement. Then if patient correctly imagine, then probably those EEG signal, some power changed in CZ area, then system that is a good one. Then stimulate the tibialis anterior muscle and make a movement. And then when system played sound, hey, try to move, imagine the left side, then left hand, try to imagine, then the C4 right hemisphere, yeah, and the C4 will be the those the EEG features are detected and the system detects, then the fast stimulation is applied to the left hand, which is extensively sternum communis. So then how the system is working? Yeah, I said probably EEG feature. What kind of the EEG feature you are using? Yeah. So here is just the text, so it may be not clear to you. Let me try to explain. And we are using the event-related desynchronization mainly. Yeah. So what is the ERD here? Yeah. So here is the ERD is the reduced EEG band power, especially for the mu and beta band. So what is mu and beta band? You may see it in the next slide. And then when the ERD appears, yeah, okay, then it's a multiple cases in ERD can observed in the EEG signal. So when we try to the actual movement, or when we try to imagine our move, not moving, just imagine itself, or someone actually passively moved our body, or when we see the movement, those multiple cases ERD can occur. Then where it happen? The contralateral hemisphere. So when I do the right one, left hemisphere, ERD occurring. When I do the left and the right, yeah. On the other side, ERS is the slightly different, is the opposite way in a way. So it's the enhanced EEG band power, and also when during the movement, and it happened in the ipsilateral hemisphere, and after movement, the contralateral hemisphere. But this is maybe not as important as the ERD. So let's focus on the ERD for this presentation. So I also extremely simplified the figures plots to explain the ERD. Yeah. So someone who wants to the right foot, imagine the right foot movement, then probably CZ is in charge of that movement. Then we show it. The CZ and C4. We are actually comparing the right foot and left hand. So we most interesting the electrode, the CZ and C4. So then CZ and C4, and then before the patient start to imagine, so it is not important, so we grade out, yeah. And then the y-axis is the hertz, in frequency in hertz, and x-axis is the time in second. Then, so here's mu and beta band. So 8 to 12 or 13, people saying the mu band. And higher is you can see this is the beta band. And the ERD appears in the mu and beta band. And also C4, the other side is some ERD can appear, but it's mainly the CZ area is more enhanced. On the other side, the left hand, patient try to imagine the left hand, opposite way, yeah? So since the left hand contralateral side, which is C4 here, yeah? So same ERD will appear in the mu and beta band. So the red one is the ERD here, yeah? ERD appears in the one cloud in the mu band, and also pick the area in the beta band. So this is the how ERD appears in the contralateral side. So another way is contralateral activation. So in our software, we actually use the top two plots only dealing with the right foot, and bottom two is always the left side. And then, so that is why the recoveriX user see the accuracy plot. Yeah, ERD is mainly for the dealing with only the two electrode, CZ and C4. But in this, after patient finish the therapy, the plot is generated by the software. How well patient performed during the therapy, and then you can see that this is some threshold line according to statistics, and then the blue one was the right side accuracy, and then yellow one is left side accuracy, and it was someone who performed really well. Then we'll see this kind of the accuracy plot, because think about it, the accuracy is still about the 50 kind of stay in the chance level, and then patient starts to imagine, then accuracy goes up, then stay there. Then in this case, patient did really well in their motor task. So once patients came for the recovery training, patient have to go through all these procedure. Yeah, they have to do almost 240 trial or the movement exercise, and then so in the end they will get the 120 stimulation or the affected side. And as you can see, there's many the repetition is really important to encourage patient to not to lose the focus. Yeah. So whenever we actually inserted the automatic break time, so every 40 minutes, so we can just make sure the patient is doing all right. And if they want to drink some the water or any some, we have already tried to check it. So after each finished the exercise run, we update the classifier and use it as a online feedback. So according to their own data, we provide the feedback to the patient. So most patients, they always ask us about what is the accuracy. So when they go home, so they are really we can see that they are really motivated to do better, and in terms of the performance and also for their rehabilitation result. So in our software, we can actually select the different therapy. So this one is for the hand therapy, and if we choose this one, then we can actually see that patient came for the left foot therapy. And so in this case, if someone select this one, it's a right foot therapy. And here is how the system is ready and set up for the patient. And then here is the therapist sitting there, and the patient is here. So in this case, patient came here for the left foot therapy. And then you can see that the wireless EEGs are there, and then two vests is connected to each side of the stimulation site. So this is our software. So you can see it. Yeah, patient have to try to imagine to touch that pink ball.
Right.
And then when they hear the right, and then they try to imagine to touch that pink ball.
Right.
So this is kind of the mirror image. Yeah. So patient kind of in the position that they are actually seeing the image of their own body by the using the mirror.
Relax.
So as you probably wonder why you're talking of the CZ and C4 in the previously, yeah. So more like the foot, in the cortex, the cortex area, who is in dealing with the foot area is actually in the center area, yeah. And for example, here the left foot is actually, this one is in charge of the foot movement and sensation, and the right hand is contralateral side, and this area is related to the right hand movement. So in this side, let's talk about someone who can do the right side treatment. Then again, this setting will be available for them, and then they will see the
Left.
So they hear that. So those left or right is obviously randomized.
Relax.
So try to minimize patients' just
Right.
expectation. And whenever they hear the right,
Relax.
try to touch the pink ball
Right.
with the right foot.
Relax. Left. Relax.
Here is one of the video. You probably have seen it, but here is the patient is sitting there, and the therapist is sitting the other side. And then when they hear it, so you have seen the avatar video, but now patient actually you can see the patient, the foot, move. The movement actually totally completely done by the stimulation. And then so you can see the patient is really concentrating the focus on the motor task. Yeah. And in the software, you can see it also, the therapist can see how patient is how well patient are performing. So you can see there's some indicating the light, green or red. So when you see it, you can see how well patient is doing. And also during the time, the therapist can see the EEG signal, something is not right, then they have to stop the software and they can fix. But usually once we start, you can see it here. EEG signal is pretty good. And you can see that this bar is moving, is actually direction of how the system is classified. Yeah. In this case, it's the right. Actually, this means only coming from using the EEG signal, system decide this is the right hand movement, and this is the match with the assigned the direction, then it stimulates the right. So patients once they started the recovery, the therapy, the basic protocol is patients expected to finish 25 recovery session. Yeah, this all 25 days. Then we actually expecting the patient has some nice improvement. Obviously, according to their when stroke occurs and how often they come and what's their age, and or especially where is the lesion location, damaged brain area is, then it can many things happen, and the improvement could be very different. So what we really noticed that is, yeah, good therapy is really important, but we also have to report how much they are improved. Yeah, so that is why I also want to show how do we evaluate patient improvement. So we do the same test, the recovery training before and after, yeah, and also multiple tests. We are using the different tests because each test has its their own aspect to detect some changes. And also these multiple tests may be useful to find any kind of the improvement. So they have done any kind of the training, but they don't know how much they are improved, even though is there. Then it'll be so, they mean, okay, I'm not getting better, and they may actually just stop it. Yeah. So it is really important to encourage them or to show how much they improve. So here is the different tests here. And one of the important thing is video recording. We have sometimes patient is a little bit negative about how much improved, even though we can see it, their number, yeah. But once they see the video from their own body, how much they can put movement is much better, or they're working, the way they work is got better, more balanced, then they really accept it, and they see that those improve the score again, and then they are happy and they continue the therapy or training. So here is some example. Maybe this is the dorsiflexion and the plantar flexion. The other one is the inversion, eversion, yeah. And obviously we record the time up and go 10-meter walk test. You already now know it. This is the time up and go test. They have patients have to walk the 3 meters and turn around and come back. So you measure the time from here to here, yeah, and then you measure it. So 10-meter walk test, and also you measure the time, but you only measure the 6 meters, so excluding the first 2 meters and last 2 meters. Then here is the one example, how you meter walk test. So here is the result. So what happened after recovery therapy. So just before we go further, I would like, you probably have seen the paper, but we last year, 2023, in October, we published the result for someone who did the lower limb therapy. And the main result I would like to share with you is the time up and go 10-meter walk test. S means self-selected, just normally they walk, and the FP is the fast walking speed. So you can see those patients that improved, which this is the time. So here is the median mean, and statistically they significantly improved in the walking test. So you can see this is actually expressed in the speed. You can see the speed before the therapy and after therapy. You can see it improved, and the normally walking speed and fast walking speed also they are improved. So here is one of the example of the lower limb patient who took the lower limb therapy. You can see it in the before is a little bit about the 47 second, but it's this is session number, and this is the after therapy, and then you can see some trend that the time actually reduced, and also walking speed is also actually also time is reduced, which means the speed improved, speed got faster. And as you can see, the fast walking speed is not possible until the 16th session and even 21 session, but the post-assessment patient really be able to walk in the fast walking speed. This was a big change. So based on our study, and also here is there's ongoing the patient training. You can see it here, and this is time up and go test. You can see it actually here. His daughter actually helping him in holding his right arm, and then here you can see she's just touching it, yeah, not helping a lot. Almost like double times faster. So in the first, even like he's having some trouble in turning. Yeah, I think that is maybe enough for now. And then after the therapy, the father and the family, I was very happy with the improvement. Next one is you probably seen it, this one. So actually the interesting thing was her goal. So this patient goal before the therapy, and she said, okay, I want to work without the stick, yeah. And then after therapy, she was actually working without any kind of assistive device. So that was she achieved her goal, and it was really nice. And she's actually coming back for she had already been here multiple times for the further training. So she's keep improving, and you can see she's like soldier, yeah, marching really toughly with the confidence. So here's the reference, and then this is what I've prepared for today. So some question, and feel free to ask me.
Thank you very much, Mosi, for the nice presentation. Dr. Rishab Pathak is saying hello to you, Mosi. So what's the reason for having 2 electrodes over the muscle when you're doing the fast stimulation?
Why do we have the 2 electrode on the muscle for the stimulation?
Yes.
If you're talking about why the 2 is because we have to the stimulation have to stimulate the muscle, yeah. So we need the plus and minus, yeah, anode and cathode, the electrode, and there should be those electrodes should not be touched directly. So have some space, and then current will go under the skin and go through the patient muscle and the nerve, and then like that way, yeah. So then that's why we need the 1 pair of the fast electrode for each stimulation side. So I hope that I answered your question.
Thank you very much. Another question is what happens exactly in the paradigm between second 2 and 3.5? Maybe you can show
I
the
see.
slide again with the paradigm so that
Yep,
people can
I
easily
think that is also
understand.
the good question. So hopefully I can find it really quick. 1 second. So that is the main reason is that it usually take 1.5 seconds until we observe the, okay, how about this may be the good slide. So you're probably talking about from the patient start to imagine like the 2 points, but why this ERD or feedback start 3.5 seconds, which is 1.5 seconds later. So many researchers have observed, yeah, usually how long does it, as you can see it here, ERD usually strongly appears in 1.5 seconds later. Yeah, that is why there is the gap, the delay, the phase will start. Yeah. So basically the answer is the ERD usually appears the 1.5 seconds later from using the EEG. Yeah, obviously we put the invasive electrode into the brain and we just measure it. Yeah, then it probably instantaneously you will observe it. But the ERD is dealing with the power, and that is why it takes some. Yeah.
Then Chapnet is saying, I'm practicing neuropsychology and I would like to test this software with my patients. This is only possible after a therapist underwent the product training. It's like for an fMRI machine. So people must be educated on the medical product to be allowed to use it. It's exactly the same with recoveriX. So people can purchase it. They can come here and get the training. And after they have got a qualified training and passed all the testing and the exam, they are allowed to use recoveriX with patients. And this is also the requirement. So it's not an open source version because it's a medical product. So it's under strict medical control. And for that reason, it's just not possible to have it open source. Then somebody's asking, does the paper report of confidence interval for the pre and post assessments?
Pre and post assessment interval is about 2.5 months. Yeah. So basically we have done it 2 or 3 times per week. And for the total amount of the session is 25 session. Yeah. So usually, yeah, that takes time. And yeah, some actually the literature have done like some daily base, yeah, or some is actually longer, maybe 1 times per week. But yeah, so we have tried. We actually the average, what is the good intensity, how often we have to do the session, the training. So we tried 2 or 3 times per week. That is the average number of the session per week, and over the 2.5 months.
And Sarah is saying, thank you very much for the great presentation. Very nice, Rosie.
Yeah.
She's asking, did the patients receive any additional traditional therapies in parallel to the BCI one?
Okay, there is also the good question. So we, someone who already, okay, for the study, we actually do not recommend. We just ask them to just purely for the recoveriX therapy, but actually someone who come here for the actual rehabilitation training, we actually encourage them to do it. So this kind of recovery can be still add on, or it will be more effective for the patient. Someone when they do the together, yeah. So there is, I think that is most people will agree with me. And yeah, someone who wants to have the nice rehabilitation effect, then they have to continue doing. And with the recoveriX. That will be my recommendation.
And have you compared traditional therapy with the recoveriX therapy?
So we have actually the results, and then we also compared how much they improved. There is the hand, for example, hand therapy, Pugumaya assessment is the primary measure. And when we compared those numbers, yeah, it was a little bit higher than the conventional therapy, could be the physiotherapy or the other therapy. And also you can actually, if you want to know more about it, there's a multiple meta-analysis using the BCI for the stroke rehab. And also if you check it, those also some papers use the FAST device as a feedback. And then you can see FAST BCI has also pretty higher than other BCI system using the robot or like that.
And Jacob is asking, are you doing also recoveriX therapies for patients with incomplete spinal cord injury?
Yes, we have actually the great success in the spinal cord injury patient, and about late last year, there's one patient came for the spinal cord injury. He actually fell from the roof, and he can walk with the stretchers, with some assistive device, but we had a huge improvement in the patient. We had actually multiple cases. In multiple cases, there's a spinal cord injury patient who improved a lot. Yeah.
Somebody is asking, is the recoveriX protocol standardized or is there room for modifications?
Yeah, we have the recoveriX therapy is standardized, and because we have tried and we followed the protocol and last 7 years. But someone who others have the better idea, they can improve and modify, and they can apply, and they try to find the more efficient way. But what from the long period of the experience, we have a standardized protocol. We recommend.
And David is saying, it's complicated. Annyeonghaseyo Mosangcho. Any idea what I'm saying?
Yeah, wow, you have a good pronunciation.
What does it mean?
Hi, Usang.
So the question is, how does recoveriX harness neuroplasticity to promote motor learning and rehabilitation for the motor deficits associated with chronic conditions like foot drop?
Okay, so let me talk about the benefit of the foot therapy using the BCI, because there's not many tools available, the fancy high-tech rehab tool for the rehab is basic patient who somehow have to be able to stand up, and then all the technology supporting them to work, yeah, for the rehabilitation. But as you already seen in the video, our therapy patients still sit, and then they do a lot of the repetition and practice and training. So there will be the thing is a big help to bridge someone who severely impaired patient to take them to the very higher level, which can be available for the other therapy. Yeah, will be great bridge. And going back to your question, so someone who do a lot of the practice foot movement, yeah. So in the brain, and the motor learning will occur, and patient will learn how to control the impaired body. And then I think this is very scientifically proven that there's many evidence that patients can improve only in the brain will be reorganized, as you trained to that movement and goal-oriented movement therapy. And also during the stress stimulation, muscle is getting stronger and be ready to move more the range of the motion and be able to work. And also spinal cord injury played a role. You can not see it, directly.
Thank you very much, Wolfgang. This was very nice. Very good
Thank you very much.
explanations.